that I couldn't even see, but the dermatologist had some magnifying glass. So I said, sure, what do I do? So I showed him today. Anyway, that explains the white face paint coat. How are you doing?
I'm doing good. How are you?
Thanks for bailing me out. Appreciate it.
Yeah, of course, of course.
And don't forget, I think the ad's going to go out. If you have any current fellows that might be looking for a job, you have
Yeah.
1 year or 2 year?
We have one this year. We're gonna have two next year.
Okay.
So we kind of rotate.
Yeah, I'll put the ad out. Actually, do you have any, yeah, you're looking for fellows as opposed to hospitalists, but I got to develop, maybe what I'll do is, if you don't mind, I'll run my ad by you to see if I think I've got the right components in for the job description.
Sure.
Okay.
Yeah, of course.
Are you still doing the 49er stuff?
Yeah, I'm at the game this Sunday actually. I'm
Really?
going. I went to the last game and I'm going to the next one.
Oh, the Green Bay game was brutal. Last Aaron Rodgers, though, what do you expect, right?
Yeah, that last series. I mean, you just gave him too much time.
Oh,
But Jeff Manley was on the Packers sideline and had like 4 or 5 evaluations. It was busy.
oh.
Yeah.
Did you have any?
I was up in the booth, so
Oh,
I
were you?
just got to kind of enjoy. Yeah.
Who was on the sideline that game? Mitch?
No, it was Tarun was on the 49ers sideline. Tarun Aurora.
Does Mitch do it anymore? Yeah, he still does. Huh?
He's doing it. He's doing it on Sunday with me, him, and Mike Wong.
Did you get an increase or no? Same old?
Same old. Yeah.
All right, so we'll wait a couple minutes. I'm looking, there's 14 participants on. This is unusual that we did case conference this morning, 7 to 8. So it's a little unusual that we do a second presentation in the afternoon. But there's a number of people that are on. Just wait a couple more minutes before I introduce you and then we get started.
No problem. And then I can just share my screen.
Yeah, and Ignella,
Cool.
Ignella will make sure that we don't have a tri-panel. It's just your share screen. Are you guys back at work? I mean, what's this? I mean, are elective things happening? And the place looked like shut down when I was there last time. And
no, everything's pretty much back to normal. If anything, we're full again. With the autumn and winter months coming up for San Francisco. So, but yeah, everything's going.
Okay, good.
Yeah, I'll actually talk a little bit about how the whole process, the pandemic, affected the transfer center and sort of what we learned from that. And
yeah, God, I remember I was on the transfer center steering committee for years.
Yeah.
Do they still have that?
Yeah, we restarted it actually.
Do you have an electronic measure of bed capacity and that kind of thing?
Yeah, we have we use Epic, as you know, and we have like these real-time dashboards that show the current census and then like all the expected discharges, and then the ED census, transfer center board census, OR census. So it's still like sort of early days. Like the information's there. The question is sort of how do you best use it to actually make meaningful moves in real time.
Yeah.
But they're actually going to build a capacity center. It's going to look like one of those like FBI rooms with huge flat screens over at Mission Bay to kind of help. So we'll see if that works.
Oh, cool. I got 17 people. I think that's a good enough quorum. Is it okay if we start?
Yeah, of course.
All right. And thanks to everybody who's participating this afternoon. And thanks to Dr. Shah from UCSF Neurohospitalist and Associate Professor of Neurology. He's the medical director of the Integrated Transfer Center at University of California, San Francisco. And he's the director of the Neurohospitalist Fellowship Training Program, which was the birthplace, UCSF was the birthplace of the neurohospitalist and the general hospitalist programs. The general hospitalist program started by Bob Wachter, and the neurohospitalist program started by Malik. Who started it?
Andy Josephson. Yeah.
Andy Josephson, and now the chair of neurology. So Malik bailed me out at the last minute, so I owe him. We used to do the 49ers and NFL sideline neurotrauma consultants together and running the booth. And today he's going to talk about something that's appropriate for all of us, and that's challenges and opportunities in neuroscience, inter-hospital patient transfers. So Dr. Shah, please take it away.
Thank you. Just going to share my screen and put this in slideshow mode. Hopefully everybody can see that okay?
Yes. Yeah, we can see it.
Great. Well, thanks again, Dr. McDermott, for inviting me. I definitely miss you at UCSF. We all miss you, and it's great to connect with you again. And I really appreciate the invitation to come talk to y'all. So in addition to my sort of neurology focused work, I'm actually also the medical director of our transfer center, and that's across departments in the hospital. So have sort of a unique experience that I want to talk about, both as a physician taking transfer center call and especially focused, of course, on neurosciences, but also sort of as a hospital administrator thinking about the transfer center and what it means to the hospital and process improvement. I have no relevant disclosures for this topic. So what I want to talk about today, I'm going to go through some literature that exists looking at interhospital patient transfers. And a lot of the papers are sort of very broad reviews of all interhospital transfers, a focus across disciplines, looking at sort of, patient factors, why patients are transferred, and also patient outcomes and what happens to these patients. And then I also want to talk a little bit more specifically about some data we have from UCSF regarding neuroscience transfers, comparing with data across the country. And I just want to highlight that the whole hospital transfer process is incredibly variable around the country for a variety of different reasons that people can imagine, but also that this data also highlights some potential disparities in access to subspecialty care, which obviously we think is one of the biggest goals of interhospital transfer. Then I'm going to switch gears and sort of talk a little bit more about some work we did specifically at UCSF in our transfer center around the time of the pandemic, sort of gave us a chance to kind of reboot and look at our processes and see what we can improve on. And I want to share sort of things that we learned and some strategies and tips that may be helpful for y'all at your institution. And then at the end, just talk very broadly about some future directions and things that might help as we think about leveraging technology and more advanced networks of care. So, I think in terms of why we want to do interhospital transfers, I think, one of the biggest reasons is obviously from a patient level, but we want to give patients access to subspecialty care. And this is especially true in neurosciences. There is not enough neurologists and neurosurgeons in the country to care for the growing population, but also the aging population. We're going to have more and more neurologic problems. And a lot of these subspecialties are sort of centralized in big cities. So a lot of people in rural communities just don't have access to care in neurosciences. We can provide very complex neurosurgical care and expertise. There's obviously a lot of work around transfers for acute ischemic stroke, bringing patients in within a timely fashion to do thrombolysis and embolectomy. On our service, we're offering electrophysiologic testing that is not routinely available at other hospitals, including continuous video EEG monitoring, inpatient EMG and nerve conduction studies, access to very specialized radiology diagnostic testing. We get a lot of referrals for second opinion, mystery cases, very rare diseases that a lot of practitioners don't have a lot of experience with or exposure to, and we have the benefit of having a broad faculty and research interest. Obviously, there's a big benefit from an education and research perspective at teaching hospitals. And then, of course, there's a financial benefit. Historically, across disciplines, transfer center patients have a higher contribution margin, bring more money in per case even for the similar diagnoses compared to other admission sources. However, does this actually lead to improved patient outcomes? Before I get to that, this was a paper from 2012 that kind of just summarizes some of the risk benefit of transfer, some of the benefits we already talked about. I think one thing from a patient level factor, sometimes patients want to feel like they did everything possible for their loved one, that they got their family member to, the sort of biggest hospital in the area and got that second opinion, got the last chance review, and felt like they got the best possible care. In terms of risk of transfer, there could be issues during the transfer process itself, and we'll talk more about that. Obviously, you're changing teams. There can be some discontinuity, lack of medical records, lack of information when the patient comes in. And then when the patient goes back, also making sure that they have good care and that's streamlined when they get back to their community. And then, of course, during the pandemic, we also appreciated a lot of these patients were coming by themselves. Their families weren't allowed to come. They're often hours away from where they live. And so there are some kind of other sort of human cost to transfer. So looking at some of these broader data sets, this is a paper that looked at over 1 million patients who were transferred for a variety of diagnoses, looking at a big database. And they found that overall, patients who were transferred had higher inpatient mortality, a longer length of stay, and were less likely to go home, basically. And they also had a higher rate of adverse events. And this is not necessarily surprising because I think a lot of us expect that these are going to be the sickest, most complex patients. This was another paper, a little bit smaller, about 3,000 patients, looking at patients who came into an ICU. And I highlighted just because about 10% of those cases had a, quote, neurologic diagnosis. And they also found that transfer patients had a higher overall mortality, stayed in the ICU for a longer period of time, and had higher risk of adverse events. So just kind of emphasizing that these patients are sicker, may sometimes do worse, and sort of thinking about the implications of that from a hospital-wide system. This was an interesting paper that looked, again, at a huge population of patients, I believe over 50,000 patients, and categorized them by different types of diagnoses, and then tried to do a propensity analysis. So trying to match patients who either got care at their hospital versus patients who transferred. And they try to control for things like what type of hospital they were coming from, age, demographics, disease severity, and then look to see, what was the improvement in outcome. And I think a little bit surprisingly, there weren't a ton of diagnoses within this group where there was actually an improvement in mortality. I highlight stroke because obviously that's very important for us in neurosciences. But a lot of these diagnoses were kind of around 1, and maybe a few of them, like esophageal disorders, patients may have done worse. Now, I think this is a very complex sort of question, and I don't mean to say that transfers hurt certain patients, but I think it's interesting to look at that there's something different about these patients. Maybe there's something about why they were transferred, if it wasn't necessarily about their illness, that may lead to different outcomes. And if you look at the 30-day mortality, even those differences we saw in the first couple of days tend to go away. So just to summarize this, we know that inter-hospital transfer patients have a higher length of stay. They have a higher in-hospital mortality, but they also have a higher case mix index. Some of these differences may vary by diagnoses. And I think some papers ask the question, are there certain populations for whom transfers lead to worse problems? There have been some single center studies looking at patients with spine disease, brain tumors, for example, who also found that the patients who were transferred were more complex and had longer length of stay. We don't have a ton of information about what patients experience regarding to transfer in terms of patient satisfaction sort of studies, understanding how patients feel about the transfer process and whether they were happy. But, again, is some of this expected? These patients are coming to tertiary quaternary care centers. They sometimes are incredibly sick. And, we've had patients who show up and pass away within 24 hours with things like head bleeds or neurologic catastrophes. And the reality is that they were probably going to pass away either way, but at least they had a chance to come to a tertiary care center and get evaluated. And so I think some of this comes with patients being sicker. But I think there are other variables to think about, and I want to highlight some of those in the next part of this talk. So this was an interesting paper that actually surveyed 100 different attendings and residents in medicine, neurology, and I think general surgery, and just sort of ask them their opinions about inter-hospital transfers. And I think a lot of these themes will probably ring true for people who are on the receiving and sending end of transfers. So if you look at this, sort of the dark gray are things that they felt like happened a lot, and the light gray didn't think happened very often. But patient arrives without necessary transfer records, pretty common thing. Patients were delayed more than 24 hours. Patients and families have an unrealistic expectation of what was going to happen. And then sometimes they shouldn't have come to my service. They don't even need to be in the hospital. This also they specifically ask, which of these factors do you think contributed to patient safety? And again, things like what time did they arrive, how busy I was when they arrived, whether they had records, whether they were stable when they arrived. So a lot of these things, I think a lot of us remember even from residency when we're admitting patients, but even now, as we learn about patients, a lot of times what you hear about a patient or what you think about a patient is not necessarily true until they show up. And I think this is a common experience around the country. The same group actually did a study of about 24,000 patients and looked at when they arrived at the other hospital. And they found that patients who arrived at night had a higher chance of being in the ICU for a longer period of time and a higher rate of 30-day mortality compared to daytime transfers. And they also found that Sunday nighttime transfers had increased mortality at 30 days compared to Monday daytime transfers. So sort of thinking about how transfer arrivals work along the sort of physician and the team duty hours, when they're available, what staffing is available, with the idea that maybe patients who show up when there's less staffing, people are more busy, may have poor outcomes. There was kind of a similar paper looking at one center for neurosurgical transfers. And they found that the majority of their patients came at night, about 70%. Interestingly, they saw sort of a different effect. The daytime patients actually got to the hospital quicker, but tended to be in the ICU for a longer period of time and had a longer length of stay. But the weekend patients had a worse modified Rankin scale and were less functionally dependent at the time of follow-up. So, sort of very practical and pragmatic outcomes that you wouldn't expect to be necessarily different when they show up on the weekend or a weekday, but maybe related to delays in surgery or, again, sort of how safe they are when they arrive. Another thing to think about is where the patients are actually coming from. And what I want to highlight is that patients coming from an outside emergency room versus an outpatient, versus an inpatient center may be a little bit different. This is sort of a very famous paper from the New England Journal in 1986, where they looked at patients who were transferred to Cook County Hospital in Chicago. And what they found then were that 80% of the patients were Black or Hispanic, and 89%, 80% were unemployed. And the reason for transfer, and over 80% of them, was inadequate medical insurance. And a very small percentage of patients were even sort of talked to about transfer or gave consent. And so they concluded that the majority of these transfers were for economic reasons. And they also noted that many of these patients were not even stable for transfer. So this paper and other work at this time led to the development of EMTALA laws, or the Emergency Medical Treatment and Active Labor Act. And it was meant to be a law that helps prevent patient dumping, right? So they wanted to make sure that emergency rooms couldn't turn away patients who didn't have insurance or for different factors that weren't related to how sick they were, that they had to really take all patients in, treat them, and stabilize them. And then if they didn't have capability or capacity on the inpatient side, they could transfer to another hospital. And similarly, the referring or the accepting hospitals, I should say, have an obligation to accept those patients if they're being told that we cannot care for these patients safely because of capability or capacity. And the sort of stability of the patient and the decision to transfer is really determined by the referring physician. I put this up there because the language, I think, is vague, and it's very much open to interpretation. And I'm sure many people have had discussions when they're on the phone with physicians on both sides, sort of what really is appropriate for transfer. Is this really something that needs to happen, or are there other things that can be done locally? And it can lead to sometimes tension and disagreements. And of course, people can cite violations, and that can be reviewed. So, a very important thing to keep in mind, because the transfer process for emergency room patients is very different than for patients that come in from an inpatient setting. This was a paper actually out of UCSF looking at about 500 patients who were transferred to the neurosurgical service, so a non sort of trauma service. And I wanted to highlight a couple of things in this paper. They found that about 55% of the patients came from an outside ED versus 45% from an inpatient unit. Pretty broad range of diagnoses. About 28% had brain tumors, 28% had some sort of intracranial hemorrhage. A lot of them had hydrocephalus. Another 25% had spinal lesions. So a huge range of sort of neurosurgical problems. What they found was that the patients who came from the inpatient setting were more likely to have surgery than the patients who came from an emergency room. Although the ones who came from an emergency room were more likely to go for immediate surgery within a few days of arrival or immediately after arrival. Looking at this further, this is a table that sort of compared all transfer cases, patients that were electively admitted, and patients that were admitted through the UCSF emergency room. And you can see there was big differences in the number of times they had an operation, which makes sense. Of patients who are electively admitted for an operation, huge majority of them actually do have a surgery. And a little bit higher overall for transfers, but lower for patients who were ED to inpatient transfers. However, the transfer patients had a longer length of stay, were more likely to require ICU stay or ICU days. And also there were pretty significant differences in sort of the insurance type. And some of this, again, is not unexpected given that patients are coming from emergency rooms. And one of the reasons the EMTALA laws exist is to help sort of protect patients and make sure that they can get access to care if it can't be done locally. So, they make the comment that admitting non-emergency patients to local hospitals may improve diagnostic accuracy of patients requiring urgent care and more precisely identify patients who actually need to transfer and therefore reduce cost. However, because of EMTALA regulations, tertiary centers are obligated to accept these patients. And they wonder about things like telemedicine and better integration of EMRs to help sort of streamline this process and help local hospitals feel more comfortable admitting patients and caring for them locally in certain situations. We did a similar analysis for our neurohospitalist service. So these were neurology transfers that were not related to stroke or intracranial hemorrhage. And again, had about 500 patients. About half were women, about 55% to 60% were white. The majority of them came from what are called urban cluster communities, so kind of suburbs, if you will, of San Francisco area. Many of them came from nonprofit hospitals, and actually about 50% of them came from hospitals that were identified as teaching hospitals, which is kind of interesting. Looking at the diagnoses, the most common was seizure, about a quarter of those cases, and about 15% of those patients were billed as status epilepticus, and this was kind of the referring diagnosis. And then 20% had sort of infectious or inflammatory disease, 15% had non-specific encephalopathy, and then you can see a range of other diagnoses. So again, a pretty broad mix, but definitely a lot of seizure patients. And we also looked at differences between patients who are transferred inpatient to inpatient versus from an outside ED. Both populations, as you can see in this table, were equally likely to come into the ICU, about a third of the patients, and about 20 to 25% of them were intubated, so quite ill when they first showed up. But the length of stay was noticeably different. For inpatient to inpatient transfers, they were in the hospital for 7 days. For ED cases, often 3 days on average. And the disposition was also different. And again, part of this is expected because for our inpatient transfers, we often transfer patients back to their referring hospital when their acute care needs are done. Whereas the patients who come from an outside ED were sort of responsible for making sure that they get home safely or get to rehab. But a large percentage of these patients, about 70% who came from an outside ED, just went home, didn't need rehab, didn't need a skilled nursing home. When we looked at the reason for transfer, so when they called us, we would ask, why are you calling? 86% of the inpatient to inpatient transfers, the referring hospital said they had no capability, but only 58% of the patients that came from an outside ED. And in fact, there was a much larger number of patients who were transferred for continuity of care. So no new CSF patients. Hey, I have your patient here with known epilepsy. They're having seizures. Can I get them transferred to you? I have your patient here with MS. They're having a flare. Can I get them transferred to you? So kind of interesting, the difference there, especially when you think about EMTALA. Both populations, continuous EEG was one of the most common things that we did, about 60% of these patients. So a very, very common reason for asking for transfer. And I just wanted to highlight that this is not necessarily something that's unique to neurosciences. This was one of many papers looking at trauma networks. And I like this term, secondary over triage. So they defined this as patients who were transferred from another hospital who ultimately did not need an operation, had a low sort of trauma injury severity score, and were discharged within 48 hours. And they said the incidence of this, at least in this one hospital, was about a quarter of patients. So just asking the question, was this the best use of resources? And thinking about the cost of transportation, also the cost that gets pushed onto the patient. So this concept of patients coming from outside emergency rooms being a little bit different, maybe having shorter length of stay, leaving the hospital quicker, ask the question, are we selecting the right patients for transfer? And of course, how do you balance that with EMTALA? And then just wanted to highlight, I think I've already mentioned this, but another very important thing to always keep in our minds when thinking about transfers are disparities potentially in access. So this was a big paper looking at about 6 million Medicare and Medicaid patients, a small percentage of which underwent inter-hospital transfer, but looking around the country. And just to summarize what they found that Black and Medicaid patients had a lower odds of transfer. And they said this definitely warrants sort of further investigation to understand why that might be. They also said there were just a lot of variability in how inter-hospital transfers happened. And this varied by region. It varied by region and not necessarily by hospital type or by patient severity. So they kind of said, there's just a lack of standard guidelines for how this should happen and how this is happening and how patients are selected. But that's important to think about, especially as we're thinking about potential disparities in access and healthcare outcomes. So just to summarize this, potential factors that are affecting patient outcomes, obviously patient selection, are they appropriate for transfer? There's variable practices, and that can be between, two physicians in the same group. I might be on call one day, my partner might be on call another day, and maybe we have a different threshold. That might be different across departments. Some departments sort of have a philosophy, say yes to everything. Other departments might say, they really need to have a very high need to come. And there might be differences across health systems. We know that this is variable in terms of how this is done. This could be leading to disparities. And then we talked a little bit about how the timing of things, how long it takes for the patient to come. What is that delay? How long does it take? What time do they arrive? Nighttime, daytime, how busy the accepting team is, the availability of medical records, that physician to physician communication. All of those are potential things that may lead to patient safety issues and maybe poor outcomes in transfers. And then we talked a little bit about differences between an emergency room and an inpatient transfer. So I'm going to pause there and switch gears a little bit and maybe put on my hospital administrator hat to talk about some work we did in our transfer center and just provide some tips that may be helpful. And I think one of the consequences of the COVID-19 pandemic is that it greatly affected our transfer center, as I'm sure it did around the country. We very early on started having these discussions about, quote, shutting down the transfer center. And I think the transfer center is easier to shut down, of course, compared to an emergency room or the operating room, although elective cases were also stopped for some time. We found that during that time, the number of requests for neurosciences, even if we were going to say no, just the number of phone calls we were getting went dramatically down. And again, I think that's because hospitals were anticipating surges in COVID patients, dealing with COVID patients. But I always sort of ask myself, where do the neurology or neuroscience, neurosurgical pathology go? Where do the stroke patients go? Where do the patients with exacerbations of their chronic disease, how are they cared for? sort of an interesting to think about. Because I think volumes in emergency rooms also went down in the height of the pandemic, unless they were coming in for COVID. It allowed us to kind of reflect on our processes. And then when we started to get into the recovery phase, we're opening the transfer center back up. We want to get the referral volume back. We want to let hospitals know that we're available if they need us. How do we do that? And is this an opportunity to really improve our processes? Interestingly, right before this happened, I actually was with a group of other administrators, and we toured a couple of different hospitals around the country, a couple on the East Coast, and also in the Pacific Northwest, to learn about different transfer center models and systems. And what I learned, I think, highlighted by the papers, systems were incredibly different around the country. People had different ways of doing things, different, just very simple things. But I remember one administrator telling me that, for their hospital, the transfer center was the lifeblood of the hospital, that it was one of the key core ingredients and something they really prioritized in terms of allowing for patient access. This hospital felt like, look, we're the only hospital in town. And if another hospital is calling us for help, like, no matter what, we're saying yes, and we're doing everything we can to get those patients here. So one thing we did, we actually had a quality or a continuous improvement team sort of come with us and sit down in the transfer center and kind of map out our process. So I'm sure this process looks very similar to other hospital centers, but just to keep it very simple, at some point you get a phone call, either from an outside hospital, emergency room, it could be a clerk, it could be a social worker, it could be a physician. Sometimes a lot of us get calls from our partners in the community. Somebody might know me and say, oh, I know you're on call, or I don't even know if you're on call, but can you help me with this? And here's the situation. We used to call those backdoor referrals, specifically to our providers. So somebody gets an intake or a request. In our transfer center, we have a mixed model of nurses and financial counselors, both of whom answer the phone. And they would spend time getting the clinical information, figuring out what service it should go to, calling the UCSF provider. You can imagine sometimes they would call back right away, and sometimes it would take hours for them to call back. Then the provider reviews the case and makes a decision. And again, that could happen within seconds, or it could take a couple of days. Once they're accepted, then you start working on getting a bed. So finding that open bed in a hospital that's almost always full. Getting financial clearance if they're coming from an inpatient setting. Our practice is to get financial clearance for that to sort of authorize the transfer to help protect the patients, and then actually setting up transportation and getting the patient here. So a very complex process. Many of things are happening in parallel, but as you can tell, lots of different places where there could be obstacles or things to improve upon. So I kind of broke this down into different sections, and these are sort of terms that I just kind of came up with. Things that I think are very important when you're thinking about transfer center processes that you may think about in relation to your own transfer center and your own institution as potential things to focus on. So the first thing I sort of thought of was, what is the philosophy of your institution in regards to the transfer center? And again, I go back to this hospital administrator who told me the transfer center is the lifeblood of our hospital, and we will do everything we can to bring in transfer cases. And in this particular hospital, they would get to the point where if they had no beds, they would convert conference rooms into a makeshift ward, move patients into that ward to accommodate transfer patients. They would bring patients directly to the emergency room. They would basically prioritize transfer center patients over all other admission sources because that was kind of the philosophy and their mission from a hospital perspective. And you can imagine that may differ within the hospital. It may depend on the department. It may depend on the physician. It may depend on different stakeholders, the emergency room doctors at your institution, or folks in the operating room may not be as concerned about getting transfer center patients in. But I think for us in neurosciences, we obviously want to understand how are neuroscience patients being prioritized and how are they being triaged. And if there's multiple cases coming in with different complications and different issues, who helps decide which patient's coming in? Because often we're dealing with, quote, one open bed, right? There's one bed available. Is it going to the sick patient in the ICU? Is it going to the patient coming out of the OR in the PACU? Is it going to the transfer center case? That's a little bit dramatic, but it does play out quite a bit. And then also understanding what is your healthcare ecosystem. The hospital I talked to felt like they were the only hospital in a large area. It was their obligation to take every patient. Other hospitals are often very close to other big academic centers or other big tertiary quaternary care hospitals, and it's a little bit more of a competition. So the way your marketplace or kind of your environment works obviously will influence your philosophy and your processes. And then also, how do you want to grow your hospital network, and how do you want to develop relationships across hospitals and maybe within service lines? One thing we did, we were sort of chatting about it before this talk. We reinvigorated the sort of transfer center executive steering committee. One thing I was getting a lot of feedback about was that people felt like the transfer center was a black box. They felt like we played favorites, that things were happening and nobody understood why. And so I was like, I want to get rid of those misconceptions, and let's have open conversations and all sit together and be in agreement that these are the priorities, these diagnoses, these type of patients, these service lines, whatever it might be. So we had people coming from the emergency room, the operating room, staffing for nursing, department chairs, hospital strategy folks, C-suite folks, all sort of having conversations about, okay, like, let's be open about this. Where do we want the transfer center to go? And what are our priorities as an institution? And then I think this also helped us build relationships with our partner hospitals, when we can go back to them and say, we want to prioritize bringing in your patients. You're one of our partners. Your patients are our patients, type of thing. And then we also developed transfer back agreements so that when patients were done with their care here, they could go back to the referring hospital. And we had that built-in relationship. I also talked a lot about a customer service model. I know as a physician taking these calls, I probably would roll my eyes at myself at this point. But I think sometimes when we're stressed, we can be unpleasant. We can be not the most kind when we get transfer requests. But I think it's important to realize that when you have potentially a negative interaction, it influences whether that physician is going to call your hospital or UCSF, I was going to say, the next time. And so you want to have these kind of very professional, cordial relationships. You want to be available, and you want to make sure that even when you're saying, no, I don't think this patient needs to come, that the next time they call, they're going to still call you because they felt like, hey, that person really talked through the case and spent time with me, and I appreciated that. And I understand they didn't need to come, but I'm going to call them the next time. We also spent some time talking to our high volume referral centers and asked them, what are your pressure points? What do you want? And what they told us is not surprising. They want to be able to talk quickly to a provider. They don't want to go through a nurse and an administrator and be on hold. They want to talk right to a doctor or a care provider who can accept the patient. Obviously, they would prefer somebody who can make that decision right then and there, but they understand that at a teaching hospital, could be a resident or a fellow. They want to make one phone call, get a yes, and then be done with it. And the rest is taken care of. The patient makes their way over. They want to know very clearly, when is the bed going to be available? When is transportation arriving? Is the patient actually transferring? I know that Dr. Shah accepted the patient, but they're still here. And they want the transfer center staff to be working with a sense of urgency. They also told us over and over again that, we send patients sometimes to UCSF, but we don't know what happens to them. And I think this was especially true for emergency room doctors. We never get feedback. How did my stroke patient do? What happened to my patient with the brain tumor? And so we've been trying to send them messages, give them feedback, let them know what happened, whether it's like a quarterly report, more invigorates, M&M. I think they really appreciate understanding what happens to their patients, and again, helps build those relationships. We also talked a lot about that sort of initial triage piece. So like I was mentioning, there's a lot of variability in how the physicians and nurse practitioners who were accepting patients were contacted. So some would say, call my cell phone. Some would say, page me. Some would say, send me a text. And then some would respond right away, and some would take hours. And so we were trying to say, like, this really should be streamlined. And we want people on call for transfer center who are interested in transfer center patients, who are invigorated by it, and again, are going to be sort of developing that customer service type of culture. We also then talked a lot about, how do we prioritize our emergencies? And we came up with a list specifically for neuroscience emergencies, which are not too surprising. and really felt like, we shouldn't be wasting time getting a bunch of clinical data and having long discussions. We should get physicians talking to physicians, or we should immediately accept these patients and just get them set up for transfer. And I'll talk a little bit more about that. Like I said, sometimes a transfer is not possible, but the time you spend talking to the physician at the referring hospital, convincing them that it's safe to take care of them, or setting up outpatient care right away. Obviously, there's also telehealth and consultation opportunities to help referring hospitals and providers feel supported, even if we can't accommodate a transfer. So it takes more time, no doubt, for the physicians, but it potentially leads to more referrals down the road. Another thing that I heard from a lot of our providers is, somebody handed me this transfer center pager when I became faculty and said, answer this page and accept transfers or don't accept transfers. But nobody told me how to do that. Nobody told me how to do clinical triage when I can't see the patient. Nobody told me what exactly my EMTALA obligations are. And a lot of us learn that as we do it more and more, and it gets easier with more experience. You can sort of help anticipate, I have a patient with a head bleed in an outside emergency room. Yes, I'm going to accept, but here's the blood pressure parameters. Here's what you need to do to get them stable to come over, et cetera, et cetera. You can imagine when people first start and they're not doing this routinely, for example, in residency or other types of training, it can be pretty daunting. So I think that's an important thing to think about, and developing what I call a boot camp, or some sort of instruction manual, seminar, something to help educate faculty so they understand exactly how the process works and what their obligations are. Another big thing, of course, is hospital capacity and throughput. So one of the biggest barriers we often deal with is we accept the patient, but there's just no beds in the hospital. And so it's always important to remember that the hospital is a series of inputs and outputs and people moving through, and the transfer center is one input. But if patients aren't being discharged in a timely fashion, if they're not being downgraded out of the ICU, if they're not sort of continuing their care, it's going to lead to transfer center patients waiting, going to other places, or never coming at all. So again, how do we prioritize transfer center patients compared to other admission sources? How do we make sure the transfer center staff have enough people to answer the phone and to actually help triage cases? If they get multiple cases at once, you don't want an emergency case to be sort of waiting because another one's already in the queue. And we're talking about developing what we're calling a capacity command center, where we sort of have these screens, dashboards, looking at all kinds of live metrics. What's the current hospital census? What are the expected discharges? What's the ED census? What's the OR census? How do we sort of navigate this very complex sort of living organism to make sure that we're getting our transfer center patients in a safe way? One thing we did that has been very successful is actually developing what we call rapid transfer beds. So, we talked to our nursing staff and said, for these neuroscience emergencies, we're always going to say yes. There's almost never a debate. If someone has bleeding in their head, someone has an ischemic stroke that needs embolectomy, someone's got status epilepticus, well, those are things that definitely need to come and definitely need help. And so rather than wait to get a hold of the physician, we empower them to get the basic story and say, yes, on behalf of UCSF and these teams, we accept the patient. Let me get you connected with our physician, but I want you to go ahead and start working on transportation and getting the patient coordinated for transfer. And the reason this could be effective is that we developed a model where we have a 24-hour, 7-day-a-week physically available bed that's continuously staffed by a nurse that's available just for these neuroscience emergencies. So we started in the ICU. We actually have one in the non-ICU as well. And we're using that not necessarily for neuroscience emergencies, but for patients that are coming from partner hospitals that are high priorities that we're affiliated with. Patients who are coming for a procedure that might take a day, they get the procedure and they go right back. So really trying to allow patients to come quickly, not have to wait for a long period of time, get their care, and then potentially go back, as well as dealing with emergencies. And so one thing we were measuring was something called transfer center efficiency. And what that was the number of transfers completed over the number completed plus potential lost opportunities. And those were cases, for example, that didn't come because we didn't have a bed in the hospital, or ended up going to another hospital, or there was some factor like lack of financial clearance or something that we feel like, boy, if we had been faster, we could have got that patient here. And what we found was that for patients who met the criteria for rapid transfer bed, 95% of those patients were completed transfers that actually came to UCSF. A very small number ended up going somewhere else. And overall for neurosciences, we saw about a 10% increase in the efficiency of transfers with this process in place. So a huge difference. And of course, you can imagine strategy got involved, marketing got involved. We started, advertising this, so to speak, to our partner hospitals and our community hospitals that, hey, we have this available for patients who need this, and we're happy to help in different ways. Transportation is a real big issue. And to be honest, I think something we really struggle with. I learned a lot about ambulance regulations, more than I would ever want to know, but in California, at least, there's very specific county regulations. So ambulances in one county can't necessarily just go to another county and pick up a patient. And that was really challenging for us because all these counties in the Bay Area are very close to each other. Hospitals and insurance companies have contracts with specific ambulance companies. And we would get feedback from providers that, hey, if your hospital had its own transportation system and can come pick the patient up, boy, we would call you all the time. And that's not something we have currently. We're obviously exploring different opportunities, thinking about also air transfer opportunities. But I think this is a big issue probably around the country, and would love at the end to hear people's thoughts about other ways to deal with this. So to summarize about transfer center processes, there's a ton of variability around the country with staffing, prioritization, how we select patients. Not all the tactics I mentioned would be appropriate for every hospital, but I think having a QI or a quality and safety team, continuous improvement team, actually look at your methodologies can be really helpful. And I think we heard over and over again that referring providers really want to hear feedback. They want to hear what happens to their patients. So just some key points I think that we covered already. There are clear benefits to inter-hospital transfers from the patient, physician, and hospital perspective, especially for neuroscience disorders. These patients are more complex and ill. They have a longer length of stay and a higher rate of in-hospital mortality. And their outcomes may vary by diagnoses, and there may be certain transfer-related processes that affect patient safety. Patients coming from an outside emergency room versus an inpatient center may have different characteristics and outcomes, and we saw that in neuroscience populations. And I think there are important disparities in healthcare access that we all need to think about from sort of a broader way to make sure that we're providing equitable and fair care and access. The process itself is very complex with lots of different obstacles. There's, again, a huge amount of variability. I was sharing sort of how we do things, but many of the things we do may not be true at other places. And then just to highlight some of the different sort of factors we talked about. What is the philosophy of the transfer center? Developing that customer service model. How do we best select patients and do clinical triage? How do we work in a system where the hospital is always full and prioritize transfer patients? And then the last thing I want to do is just talk a little bit more broadly, maybe a little bit more pie in the sky about things that I think will be very important in the future. I didn't touch on it, but I'm sure many of you are thinking about it. But neuroimaging is a huge part of transfers, especially for neurosciences. Many of us have had the experience of not being able to see an image before the patient shows up. They show up, and what was called something or what was thought to be something is very much not that. It's either a lot worse or it's a lot better, et cetera. And so having really good systems to quickly share imaging that's protected from a privacy perspective, effective from a resolution perspective, can really help with patient selection and potentially help avoid misdiagnosis. I know a lot of people are basically sending each other cell phone pictures and videos, which is effective sometimes, but obviously can come with some cost and some patient privacy concerns. I think telemedicine is obviously here to stay and a potential big opportunity to help with these type of populations. This is one of many papers I just put up there. This was a paper looking at within the VA system, which is obviously sort of an established network, doing telemedicine in the ICU, sort of a larger VA hospital with intensivists actually rounding, quote unquote, virtually on patients locally. They found that system led to better patient outcomes and a lower rate of or need for inter-hospital or inter-network patient transfers. So you can see how there may be opportunities, although logistically challenging, where telehealth may help us with patient selection as well and help referring hospitals feel comfortable caring for patients that may not need to be transferred. For neuro hospice, sort of our patients specifically, or the non-stroke patients, one of the big reasons for transfer is a need for continuous video EEG. I think that was very clear in our patients, and I'm sure that's true around the country. And so, I think one thing that we're always thinking about is how do we get hospitals better access to EEG? There's good studies that even a 2 or 3 hour EEG can be invaluable to help rule out status epilepticus or help triage which patients actually need sort of continuous EEG monitoring, help you sort of titrate sedation for patients who are intubated rather than wait several days for a hospital to be available. And this was one paper highlighting sort of an effort to build an infrastructure for continuous EEG at a sort of medium-sized hospital, and they actually showed quite a bit of benefit from a cost perspective. They were able to reduce the number of transfers that were necessary and improve outcomes for patients in the ICU. So something definitely thinking about, obviously a big problem, not only for inpatients, but for outpatients as well, just getting good access to higher level epilepsy care. I think with stroke, there's been a lot of work, very sophisticated modeling about how to develop networks of care. How do we get patients who are having a stroke to a place where they can get embolectomy and thrombectomy in a timely fashion? That's obviously incredibly important. But I think a similar model can be used for other neuroscience emergencies, status epilepticus, neurosurgical emergencies. We know models exist for trauma, for example. But there may be ways that you can imagine a system where you have, hospitals, maybe critical access hospitals where there's no neuroscience coverage. You have other hospitals where there's some neurology and neurosurgeon coverage, and then you have larger hospitals where there's subspecialty care. And maybe the critical access patient doesn't necessarily need to come to the subspecialty super huge hospital right away, but could go to the hospital that has a little bit more access to neurology and neurosurgeon, depending on the acuity of the case, the complexity of the case, whatever it might be, and get the care they need safely, quickly, and at probably a lower cost, while also keeping sort of a bed open at the TQ center or the tertiary quaternary center for the more complex cases. So I think more and more hospital systems are doing this. And I think one concept is having really a centralized transfer center where you get a call, you get a clinical story, and you triage it not only by acuity, but also to which hospital. Okay, this patient might be best for this hospital. Let's call this doctor to see if that's appropriate. This case might be more appropriate for this hospital. And you can use things like geography, patient preference, insurance relationships, et cetera, to help make those decisions, but allow people to get access to the care they need without necessarily having to come to a place where there may be very few beds available for a broad population. I think one thing I didn't really touch upon, but I think is really important, is what happens when they leave your hospital. Many of our patients who are transferred are coming from hours away, either other states. We've had patients come from Hawaii, Alaska, other countries. So I always worry, like, what happens to these patients when they go back? How are we doing with communicating to local providers, local neurologists for these very complex cases? When they go back to the rural community, are they going to actually get the care they need? Or are they going to be driving 6-7 hours to come back to San Francisco for care? I think telehealth is a big boon for this. We've developed sort of a discharge clinic where we specifically see patients, within a couple of weeks of their discharge. If I took care of you in the hospital, I see you myself, I make sure that all the tests that were needed to be done are done. We go over results. And then if it's like, okay, now you need this subspecialty care, you have multiple sclerosis, I'm going to get you plugged into our MS center. You have encephalitis, I'm going to get you plugged into the right person. But at least the person taking care of them saw them and made sure that everything was sort of done appropriately and get them to the next place. So I think a lot of opportunities and things to think about. How do we make sure these patients who are more sick, or sorry, not more sick, who are sicker, more complex, actually get good care once they leave? And then the last thing I'll say is that I think it's important, if people are interested, to really do a deep dive into transfer center metrics and data. So we've developed more and more robust systems to, in real time, provide services with their transfer center volumes, and also information about cases that didn't come. So where were those patients being called from? Where did they end up going? Why didn't they come? I think this is important for a lot of different reasons. One, you want to see how your strategy and outreach things are actually helping. You want to see if there's certain hospitals you want to build relationships with, or there's hospitals you thought you had a relationship with, but all of a sudden the referrals are going down. How do you engage them and have those conversations? I think having data is obviously really important. Having this information can be helpful for strategy, for marketing, sort of helping you develop that network. And so a lot of our service lines, not just the neurosciences, but our transplant team, our heart and vascular team, are very, very interested in learning about what's happening in the transfer center, where are these patients going if they don't come, what happens to the ones that do. And then also that helps them provide feedback, helps them do M&M and didactics for the referring physicians and referring hospitals. So for folks who are interested, I highly encourage it. It's definitely a lot, but I think you can be really powerful using these tools to improve your processes. So I'll pause there. I want to thank again, Dr. McDermott, for inviting me. And I just have the list of my colleagues in our neurohospital division who have been really amazing colleagues. And I love working at UCSF and love working with these people in particular.
Thanks, Malik. That was great. I was, I guess maybe I shouldn't be surprised, but I was surprised at how much data there was in the literature about this process, which is complicated, frustrating, always requires endless revision of process. But I really like the idea about giving feedback to the referring docs, which is not only is it courteous professionally, but it's also educational. Because I think as you showed, most of the time or more often than inpatient-based transfers, the ER-based transfers, the diagnosis is not known, and it's just the ED is crying for help. And so I used to say to our residents that if somebody calls for a transfer, most of the time, hopefully it's because they need help, and therefore, if they need help, the patient needs help. I like the idea about training for transfer center responsibilities. It's true that you frequently get, your chairman will call you up and say, hey, you need to do your turn in administration. I want you to rotate on the transfer center steering committee, but it's not, once you get involved in it, even though it sounds like it might be mundane and quote, a waste of time for surgeons, it's actually, you realize that you have an incredibly valuable role to play and can be very informative with input based on your experience in your department. I agree with you that putting somebody on a transfer center steering committee or responsibility for triage on their operative day, when they're, or their research day or whatever, where they're not clinically available, is a mistake. And that's a simple scheduling problem, which people frequently overlook. I don't think we have a transfer center steering committee here. We tend to get most of our transfers from hospitals within our healthcare system, as opposed to being like a university system where it's the last source of hope, so to speak. We don't really function the same way. But on the other hand, there are challenges, particularly related to stroke. And one of our interventional neuroradiologists, Dr. DeBoos, has a question, so I'll let him take the mic. Guilherme?
Thanks, Mike. Well, first of all, Dr. Shah, great presentation. I really enjoyed it. A lot of data that you showed is quite interesting. So as Dr. McDermott mentioned, our transfers are mostly from our own network, right? We have a spoke and hub and spoke model. So basically, a lot of our other hospitals don't provide any services, even like neurosurgical services. So the patients need to come here for treatment. So I have like just a few questions based on those same lines, because it seems like UCSF as a major tertiary referral center really gets patients from, other networks, other health systems, as you mentioned, across the ocean from Hawaii. Are the only patients that we get from that are actually the patients from the Caribbean that once in a while will come here. But so, my impression is that, and being a fellow at Mass General many years ago, we were pretty much an open center. You know, they would call, it was pretty much transfer, because we didn't have a network. Those patients were coming from New Hampshire, from other health systems. So there was really like a little bit very open, just transfer, because we don't want to lose that referral. And it seems by your presentation, it's similar, the approach that UCSF has for the transfers, which is a little bit different than what we have here. We try to be a little bit more selective, even because the hospital capacity is an issue. So of all those calls that are coming through your transfer center, how many really are declined or felt not to be appropriate and not transferred? Number one. And the other, I don't know if you have this data, but it would be interesting. And this may explain why, when you look into your data, the transferred patients tend to have potentially worse outcome, because they're, as you mentioned, they're more complex. So how many of those transfers are related just for, you know, to provide care that was not available on those hospitals, meaning, you know, there was no neurosurgical or neurointerventional service on that hospital, and the patient needs to be transferred to CSF for thrombectomy or for an aneurysm treatment, clipping, whatever it is, versus the cases that come from networks that do have that type of service and are just being transferred because at that hospital they didn't feel they have the capability, either technical or, you know, imaging wise or equipment wise, and needs to be transferred for really more like a more proficient care at UCSF. Do you have the data?
We do. I don't know if I know the numbers off the top of your head, but I think you bring up a good point. I mean, it sort of highlights some of the things I was talking about, that different transfer centers have different priorities and different sort of missions, if you will, right? So, and I think that's also, that can vary across departments. So I will say at UCSF that there are departments, the neurosciences certainly being one of them, that have that philosophy, like Dr. McDermott said. If somebody's asking for help, a patient's asking for help, we're basically saying yes. And that sounds like that was kind of your experience at Mass General as well. And so those patients, you know, what we call the transfer efficiency, kind of the rate of patients that we accept and that actually come versus ones that go other places, for the neurosciences is basically around 80%, and that includes neurology. Whereas other services, probably the most clear example is hospital medicine, which really has a different sort of philosophy on it. They're not really prioritizing transfer center cases. They're really focused on taking care of patients coming in from the emergency room, coming in from clinics or urgent admissions. And they probably have an efficiency around 15 to 20%. And basically they have a census and they don't go above that census. So they're not, you know, they're not making conference rooms into wards to bring in patients. They're sort of like, this is our model, this is our staffing model, these are the patients we can care for safely, and sort of full stop. So it sort of highlights that there's differences within departments, divisions in terms of what they want to accomplish to the transfer center. And there's no right or wrong. It's just a matter of sort of what your mission is as a department or as a hospital system. And for us, it's very clear that services like neurosciences, our transplant team, our heart and vascular, are hungry for transfers, want to build those relationships, want to build, and I should say oncology as well, and get more transfer patients. Whereas other services have plenty of volume coming in through the usual ED or their clinic direct admissions, and are not necessarily, you know, taking in a lot of transfer cases and triaging things differently. And I think that's probably true when you're thinking about, like, it's a broad network, but it's kind of a closed network. We have, for example, Kaiser, maybe analogous system. We have Kaiser system in California where they have one big neuroscience ICU center in Redwood City, which is a little bit south of San Francisco. And they're meant to be the hub for, you know, traumatic brain injury and for certain sort of neuroscience emergencies. And all those patients get transferred there for that care. And then the other hospitals take care of other neurologic cases. Most of them are all doing TPA and embolectomy, but even some of those are transferring within the Kaiser system. So that seems a little bit more similar to what you're describing. And you can imagine where the threshold for transfer and sort of the philosophy is going to be a little bit different, because it's not necessarily like a financial incentive from the institution standpoint. There may be different incentives from a physician workload, right? Or like how much, like there's different, there's other variables when you're on transfer center call that may influence your decision, to be honest, right? Whether I'm going to take a patient. And so those things may be in play when you have a different ecosystem and sort of a network that are, I think, really important to highlight and think about whether that's appropriate for neurosciences versus other systems. I hope that answers some of your question.
Yeah, I really appreciate it. Thank you so much. Yeah, it definitely answered it.
Hey, Malik, you mentioned that transfers are a potential source of revenue. Do you have any idea what the indirect contribution margin is for quote transferred patients versus elective admissions? That's the
Yeah.
hospital side equation. I don't know if you know that or not.
I don't know the numbers by detail, but what I've been told jokingly by some of our financial people is if they could choose, they would close our ED and just accept transfer center patients. So I think that speaks to the concept that even a medicine transfer patient, a hospital medicine transfer patient, is going to bring in a higher contribution margin than an ED hospital medicine patient or an elective admission.
Yeah.
And I think that's definitely true for neurosciences. The margin may not be as wide, let's say for neurosurgery, because a lot of those patients who are elective admissions are going to get surgery, but certainly probably wider for non-surgical services
Right.
or certain other types of services, especially for us in neurology, where
Right.
our elective admissions are like, they're coming in for IVIG or they're coming in for an infusion. We're not gaining a ton of contribution margin as opposed to a sicker patient is getting EEG and a bunch of other tests.
Yeah. Yeah. Therefore, I can imagine that the economics of an ED transfer versus an inpatient transfer favor the inpatient transfer for obvious reasons.
Yes, there's a different.
Yeah. Mm-hmm.
There's a different payer mix, right? Because at least the way we do it, and I'm sure a lot of places do, we actually get financial clearance for inpatient transfers. So we do accept patients who have no insurance, but it's sort of like we actually have to go to our chair, if you remember,
Right. Yes.
Dr. McDermott. So I think those patients have more likely to have commercial insurance rather than emergency room patients where we don't ask and we're not supposed to care and we don't care. We just bring them in.
So the way it used to work when I was involved in the transfer center and took call for transfer center was that if an uninsured, if they're in the emergency department, no question, it's just transferred. But if they're an inpatient and they're and they do not have insurance, then the way it worked was the referring hospital has to turn around and make the referral to their county hospital equivalent. If that county hospital equivalent refuses the transfer for lack of capacity of expertise, which is the famous phrase they always use, we have no capacity to care for a patient like that, then once the county hospital refused, then our hospital could establish a contract for care that would be paid for by the county hospital. And then we would take the patient. We would not take the patient if there was no documentation of insurance status. And if the referring hospital did not make that attempt to refer to the county hospital, we would need a record of the refusal by the county hospital to accept the transferred patient. And that's the way we would actually ensure getting some payment. So I think it's very difficult. I always used to, as a resident, I always used to look at it as a challenge when I heard that somebody's being transferred in, because I assumed that the diagnosis was wrong and it was my job to figure out what was really the matter with the patient. So I kind of thought of it as a bit of a challenge and fun. Dr. Ziffer, your microphone's active. Did you want to ask a question?
No, I got a message to unmute. No, let me make a comment. It's extraordinary the way you conveyed the importance of a transfer center. I think, culturally within administrative environments, it may be seen as a nuisance and obviously just accommodating in talent needs and so forth. But I think your strategic vision was really very impressive. Just as a quick comment, not comparative, our transfer center is integrated with the EICU, same place. And while they're not synonymous, obviously the collaboration is really very good because the medical expertise then is there in the EICU to talk, if needed, to any outside hospital. So it's kind of a cool thing we've got. tremendous work. Thank you.
Yeah.
Oh, thank you. I appreciate that.
Malik, it's only 2:07. You got lots of work to do there. It's 5:07 here. I'd like to thank all the participants who signed on. Many of our neurosurgery colleagues were either out of town, DC and Spain, or operating or revising something in the recovery room. So, but I'm glad that everybody was able to spend the time to sign on. I think very useful information. So we thank you very much for doing this at the last minute, I would also note. So thank you, Malik. Have a good weekend.
Of course, my pleasure.
Tremendous.
Nice chatting with all of you.
And watch for the shipment from the wine house on from the dog patch from we will appreciate your the time you spent and a little token of our appreciation. So thank you.
I appreciate that. Everybody stay safe. Bye.
Thank you.